You are welcome to this section. We will be discussing abortion and post-abortion care. I am Dr. Olayemi Olaniyi Joseph, a senior registrar in the Department of Obstetrics and Gynecology, Obafemi Awolowo University, Ile-Ife. Abortion is still common in this part of the world, especially in the sub-Saharan Africa, in which Nigeria is part of, and is one of the leading cause of maternal mortality, accounting for about 8% of the causes of maternal mortality in Nigeria. So I will be shedding more light on abortion and post-abortion care. At the end of this section, you should be able to recognize abortion and unsafe abortion, the difference between the two. Also to recognize early and late complication of unsafe abortion. Also post-abortal care in the management of abortion and complications. And also to be familiar with the full range of steps in the treatment of life-threatening complication as a result of unsafe abortion, and to set guidelines for the prevention of unwanted abortion. By definition, abortion by World Health Organization can be defined as extraction or expulsion of the product of conception that weigh less than 500 grams. And unsafe abortion can be defined as a procedure of termination and unintended pregnancy carried out either by persons lacking the necessary skills or in an environment that does not conform to minimal medical standard, or both. While therapeutic abortion abortion can also be defined as termination of pregnancy performed when a pregnancy endangers the mother's health, or when the fetus has a condition incompatible with the normal life. Spontaneous abortion is the termination of pregnancy before the age of viability through natural causes, while induced abortion is an artificial and intentional termination of pregnancy using any of the numerous mechanical devices, manipulation, or instruments. And induced abortion may be therapeutic or criminal, otherwise illegal, depending on whether such an intervention is permitted by the existing law of the country. Post-abortal care, it's a package related to interventions for the management of complications of spontaneous and induced abortion, aimed to reduce maternal morbidity and mortality, as well as improves women's sexual and reproductive health. The key facts about abortion, talking about the epidemiology now, about 56 million of induced, both safe and unsafe abortions occur worldwide each year, and about 25 million of these are unsafe, almost occurring in the developing countries, of which Nigeria is one of them. And 8 million were carried out in the least safe or dangerous condition. And 35 induced abortions per 1,000 women aged between 15 and 45 years old. And 15 to 20% of all pregnancies will end up in spontaneous abortion. Some of these will suffer complications that would need emergency treatment. And each year, between 4.7 to 13.2 of maternal deaths can be attributed to unsafe abortion, and about 7 million women are admitted to hospital each year in developing countries as a result of unsafe abortion. While hospital records from the developing countries suggest that 38 to 68% of women treated for complication of abortion are younger than 20 years of age. The burden of abortion in Nigeria, about 10 to 14% of maternal morbidity and mortality as a result of unsafe abortion, and estimated unintended pregnancy rate was 59 per 100 women aged between 15 and 49 years, while 56% of this unintended pregnancy will end up in induced abortion. Fashuba et al. In 2003 did a case study with the title Illegal of Induced Abortion in Nigeria, and an examination of its consequences and policy implications for health policy makers. And the result was that induced abortion has caused a lot of reproductive problem in women, and there is paucity of concrete policy about illegal abortion. Abortion could be classified into spontaneous and induced abortion, while there are various spectrums of abortion, which includes the threatened abortion, the inevitable abortion, the incomplete abortion, the complete abortion, missed abortion, and septic abortion. And I will be dilating on each one as we go by with the presentation. Spontaneous abortion accounts for 15 to 20% of clinically evident pregnancies that will end up in spontaneous miscarriage, and 60 to 70% of chemical pregnancies will end up in spontaneous abortion, while 80% of all spontaneous abortion occur prior to 12 weeks of gestation, meaning that a majority of spontaneous abortion will occur in the first trimester. What are the causes of abortion? The causes could be classified into three. There could be fetal factors, there could be maternal factors, and there could be paternal factors. Factors from the father, factors from the mother, and also the factors from the fetus. The fetal factor, one of the commonest causes is the aneuploidy, which is a chromosomal abnormality, accounting for 50% of causes of abortion in this environment. And one of the examples is the monosomy X, which is the single most common aneuploidy, accounting for 20% of abortion. Then also a group of autosomal and trisomies, for example, the trisomy 13 and 16 and 21, and trisomy 16 has been known to be the most commonest cause of abortion. Also, the incidence of chromosomal abnormalities tend to increase with maternal age. What am I trying to do? The older the woman is, the increase in chance of her coming down with abortion as a result of chromosomal abnormality. 15% of this abortion will occur in a woman that is less than 35 years of age, while about 20 to 25% will occur in a woman at 30 to 39 years of age, while 35% will occur in a woman that is between 40 to 42 years of age, while 52% will occur when the woman is above 42 years of age. As you can see, there is increase in the percentages as the woman is getting older. And spontaneous abortion decreases with advancing gestation. And what I'm trying to say, it is likely to occur in the first trimester than the second trimester, and also it is likely and it has been found that 50% in the occur in the first trimester, while 20 to 30% in the second trimester, and 5 to 10% in the third trimester. What are the maternal factors that could be responsible for spontaneous abortion? And these include maternal infection, for example, sexually transmitted infections from the gonorrhea, from syphilis, from chlamydia trachomatis, and also from cytomegalovirus virus could also be a cause. Also, maternal medical conditions like the connective tissue disorders, for example, the systemic lupus erythematosus, the antiphospholipid syndrome, and also some maternal medical conditions like the diabetes and renal disease could also lead to the cause of spontaneous abortion. Also, uterine defects, when there is a defect inside the uterine cavity, and diethylstilbestrol exposure could actually lead to these anomalies, or if there has been a previous scarring of the endometrial lining, and also cervical incompetence. All these uterine defects could lead to spontaneous abortion. Some other maternal factors include the immunological factors, malnutrition, psychological factors, and trauma, and also toxic factors, exposure to irradiation, to antineoplastic drugs also could also lead to spontaneous abortion, and also alcohol and nicotine usage also could lead to it. Paternal factors from the father that could lead to spontaneous abortion include the chromosomal abnormalities that I have talked about before, and also advanced paternal age. How does an abortion occur? When it occurs, the pathology will result in hemorrhage into the decidua basalis, which is the part of the placenta, and there will be inflammation and necrosis at the implantation site where the implantation has occurred, and this will lead to partial or complete detachment of placenta, leading to situation of uterine contraction and cervical dilatation, which will later lead to expulsion of the product of conception. Now I will be talking on each of the spectrum of abortion that, as I've earlier mentioned. Threatened abortion, this occurs when there is vaginal bleeding during the early pregnancy without cervical dilatation or changes in consistency, meaning that the cervix is still closed, and the woman will present with vaginal bleeding during the early pregnancy, and it occurs in 20 to 30% of all pregnancies, and about a third of this will progress to inevitable abortion irrespective of treatment offered. Why inevitable abortion is vaginal bleeding in the early pregnancy with cervical dilatation, effacement, and rupture of the membrane, as against what happened in threatened abortion when the cervix is still closed. In inevitable abortion, the cervix is opened, and there could be or not rupture of the fetal membrane. No tissue is passed in inevitable abortion, and the ultrasound will show product of conception in the lower uterine segment or cervical canal. Incomplete abortion occurs when there is vaginal bleeding in the early pregnancy with cervical dilatation and passage of parts of the product of conception, meaning that there is still some product of conception in the uterine cavity while the woman has passed some of the product of conception, and this kind of patient will present with cramps and severe and persistent bleeding. The TU, the product of conception, may be seen in the vagina or seen plugging the cervical os, and the ultrasound will show retained product of conception in the uterine cavity. While a complete abortion presents with history of vaginal bleeding, abdominal pain, and passage of TU that has subsequently subsided, meaning that the woman has passed out all the product of conception, and the uterine cavity now left with no product of conception, and the examination will reveal now uterine size that is less than the period of amenorrhea, meaning that the uterine size will be less than the gestational age of the patient, as in the general age of the patient, and also the cervix is going to be closed in complete abortion. However, ultrasound will demonstrate an empty uterus in complete abortion. Missed abortion. In missed abortion, the pregnancy is no more viable and the uterus is not making any attempt to expel the product of conception, and the early pregnancy symptoms may resolve inexplicably, and the uterus is usually smaller than the expected for date. However, the ultrasound in missed abortion will reveal a gestational sac with a fetal node without cardiac activity. And also, blighted ovum represent a failed development of embryo, and ultrasound will show an empty gestational sac, and which is now called an embryonic gestation, meaning that there is an empty gestational sac without an embryo. How do we investigate a woman who has had an abortion? The investigation will range from doing a full blood count for the patient, which will include the full blood count, the differentials, and the platelet. Also, one will need to group and cross-match blood for this patient. Then the coagulation profile is important in this kind of patient. And also ultrasound to evaluate threatened abortion and to rule out other types of abortion I've made mention of. And also the histology of the evacuated product of conception, to which will demonstrate a chorionic villi, and this can actually be used to rule out gestational and trophoblastic disease. How do we manage the treatment option for a woman who has sustained abortion? If it's a threatened abortion, one will need to reassure patient. Some will need hospitalization and bed rest, and one will need to repeat the ultrasound in a week after to confirm the growing of the fetus. However, some have talked about the administration of progesterone, though this has not been proven to have any benefit in a woman with threatened abortion. For inevitable abortion, the woman needs to be hospitalized, and analgesics need to be given because of pain, and also evacuation of the uterine cavity also need to be done, which can be by medically or surgically. And medically, by the use of misoprostol, can be used to evacuate the uterus, and surgically with the use of manual vacuum aspiration to to empty the uterus. In incomplete abortion, some will come in shock. They might have bled a lot, so might need resuscitation with crystalloids, and broad spectrum antibiotics to prevent infection also needs to be given. Then after a stabilization, the retained product of conception should be evacuated. In a complete abortion, one needs to reassure the woman. The ultrasound must have confirmed the empty uterus, and one needs to assure the woman, and also counsel the woman that the chances of future pregnancy is over 80%. In missed abortion, it is preferable to evacuate the product of conception either surgically or medically to prevent complications such as disseminated intravascular coagulation. As I've said earlier, in missed abortion, the pregnancy is no more viable, and the patient will have stopped experiencing the early pregnancy symptoms that she has been experiencing, and also the fetus will be without any cardiac activity. So if it's there for a longer time, it could actually lead to a complication of disseminated intravascular coagulation. And with missed abortion, a combination of mifepristone and misoprostol can actually be used successfully as a method of medical management. And the diagnosis is usually unexpected. So counseling and support for this woman may be required. For a woman who has had an abortion, one needs to follow up. Follow up is a key in the management of this kind of patient. One needs to reassure the woman, and also contraceptive counseling also need to be offered to this patient. I'll still discuss that in post-abortal care, which is one of the components of the post-abortal care for a woman. And also psychological grief counseling also need to be offered to this woman. I want to talk on induced abortion. Induced abortion is an artificial and intentional termination of pregnancy using any of the numerous mechanical devices, manipulation, or instruments. And induced abortion may be therapeutic or criminal, otherwise illegal, depending on whether such an intervention is permitted by the existing laws of the country. Induced abortion means a means of termination of pregnancy intentionally by using various mechanical devices or instruments. And induced abortion could be a therapeutic one, probably to save the life of the woman, or if the fetus is not viable, an induced abortion could be used for that kind of patient. And also it could be illegal or criminal if one tried to induce the abortion in an illegal way, with intervention is permitted by the existing laws of the country. Let me quickly talk about the legal aspects of abortion. There is actually a law governing abortion, and this varies from country to country. For example, in a country in Nigeria, induced abortion is still illegal, except to save the life of a pregnant woman, and it carries up to 14 years jail term. And the criminal and penal code operates in the southern and northern states of Nigeria respectively. And under the penal code, an abortion can only be performed to save the life of a pregnant woman. And for the criminal code, it has been interpreted in such a way that allows an abortion to be performed to save the life of a woman, as well as for physical and mental health reasons. And for an abortion to be carried out with legal aspect, two physicians are required to certify that the pregnancy poses a serious threat to the life of the woman. What are the complications of abortion? The complications could be divided to the immediate complication, and that means early complication, and also could be a late complication. Immediate complications includes mild to moderate vaginal bleeding, shock, and also there could be intra-abdominal injury, probably during the process of committing the abortion. There could be injury to the organs in the abdomen. There could be uterine perforation. There could be injury to the bowels, the ovary, and the fallopian tubes. And also there could be injury to the ureter, the urethra, and the bladder. And also there could be complication of septicemia, which will occur with gram-negative organisms, giving the gram-negative septicemia. There could be peritonitis. There would be gas and gangrene. There could be tetanus. And also for a woman who is rhesus negative, there could be risk of rhesus isoimmunization following the termination of pregnancy. What are late complications? Late complications include secondary infertility, and this is quite common in an environment for a woman who has had an unsafe abortion, now coming down with secondary infertility, secondary to tuber factors. And also there could be secondary amenorrhea also following an abortion, and there could be cervical incompetence from as a result of forceful dilatation of the cervix, which could actually lead to spontaneous abortion later in the future, and there could be also premature labor, and there could be pelvic inflammatory disease. There could also be risk of ectopic pregnancy and chronic pelvic pain. I want to talk about a recurrent abortion. What do we call the recurrent abortion? A recurrent abortion is defined as when there is a spontaneous abortion of 3 or more consecutive miscarriages. When there is 3 or more consecutive spontaneous miscarriages, it is known as a recurrent abortion, and may affect about 1 to 3% of women of childbearing age, and could be primary and secondary. Primary in the sense that it refers to a couple that have never had a live birth, and secondary when it occurs in couples that has been having repetitive losses following a successful pregnancy. However, now the definition of recurrent abortion is changing. Now that even if a woman now has just only one spontaneous miscarriage, such a woman is qualified to be, to be said that the woman has had a recurrent abortion, and recurrent abortion often results to a feeling of grief. So such a woman needs counseling psychologically. And what are the etiology of recurrent abortion? The etiology, the causes could be uterine anatomic abnormalities, and these account for 15% of the causes of recurrent abortion, and could be classified as being congenital or acquired. Congenital abnormalities has been linked to in utero exposure to diethylstilbestrol. Also, congenital malformation that could be associated with pregnancy loss includes when there is congenital malformation in the uterus, and this could ranges from a biconate to septate or uterine diadesis. And also the uterine anatomic abnormality could also be acquired, meaning that it could result from conditions like Asherman syndrome, submucous fibroid, and polyps, and these are actually amenable to surgical correction. And also another causes of a recurrent abortion is genetic abnormalities, and this could be found in 3 to 8% of couples with recurrent pregnancy loss. And chromosomal abnormalities account for about 50% of all products of conception from the first trimester miscarriage, and 5% of late pregnancy, and 0.5% of live birth, meaning that chromosomal abnormality actually affect pregnancy early, and also a reduction in patients with live births. Also, the genetic abnormality could actually be divided into balanced translocations, and this accounts for the largest percentage of these karyotypic abnormality, and also there could be chromosome inversions also, which could lead to abortion. And hormonal and metabolic disorders too has been known to be one of the causes of recurrent abortion. For example, diabetes mellitus, thyroid dysfunctions could be causes of a recurrent abortion. And approximately 8 to 12% of all pregnancy losses are the result of endocrine factors. And also, there is a luteal phase defect. Progesterone, which is one of the hormones of pregnancy that is being produced from the corpus luteum, is responsible to prepare the endometrium for inflammation in the inside of the endometrial cavity, preparing the place for implantation, and also progesterone is required to support the endometrium until the placenta will take over the production later to maintain pregnancy. So if there is a luteal phase defect in which the endometrium lacks adequate progesterone effect, could also lead to recurrent abortion. And treatment with progesterone supplements and human chorionic gonadotropin hormones can often employed. And also, another causes of a recurrent abortion is polycystic ovary syndrome, and the exact mechanism by which this occurs has not been determined. However, possible mechanisms of polycystic ovary syndrome include a direct effect on the ovaries and causing premature aging of the oocytes, and also direct effect on the endometrium, adversely affecting the implantation. And some other infectious causes can also lead to a recurrent abortion. Some certain infectious agents like Toxoplasma and gondii, some viruses like rubella and herpes simplex viruses, cytomegalovirus viruses, and Coxsackie virus has been linked to sporadic abortion. A cervical incompetence could also be one of the causes of a recurrent abortion, and this results when there are pregnancy losses during the second trimester, and especially between the 16th and 18th weeks of gestation. And the diagnosis is usually based on the history of late miscarriage preceded by spontaneous rupture of membrane and painless cervical dilatation, which will eventually lead to the expulsion of the product of conception. Also, thrombophilia has also been identified as one of the causes of recurrent abortion, and the most common inherited thrombophilic disorders are factor V leading, and this is associated with about 25% of isolated thrombotic events and approximately 50% of familial thrombosis. And immunological causes of recurrent abortion, autoimmune disorders like the antiphospholipid antibodies could lead to a recurrent abortion. And the antiphospholipid syndrome is an autosomal disorder that is characterized by the presence of a significant level of antiphospholipid antibodies and one or more clinical features, among which are recurrent pregnancy losses, fetal death, and thrombosis. Also, there are some environmental and occupational factors that could lead to a recurrent abortion, and this includes smoking and alcohol. However, these has been associated with dose dependent to increase the rate of sporadic pregnancy loss. And the environmental factor and occupational exposure to certain products rarely have been linked to sporadic pregnancy loss. And the causes of recurrent abortion could be idiopathic, as in meaning that no cause has been found, and this accounted for about 50% of the causes of recurrent abortion. And how do we evaluate a patient that has presented with a recurrent abortion? Clinical investigation should be initiated after 2 consecutive losses, especially when the woman is 35 years age and above, or or when the couples have difficulty in conceiving, and the history is germane in this kind of patient, and the history will include the family history of chromosomal history of chromosomal anomalies, abnormalities, history of diabetes mellitus, also a social history of alcohol or smoking, past medical history is also important. One wants to know whether there has been history of thyroid disorder, autoimmune disorders in this patient. Then gynecological history and past obstetric history to know whether there has been previous history of abortion or miscarriages, and the time that they actually happened is also important when taking history from these patients, and the circumstances that surround each pregnancy loss too is germane, is important. And what are the investigations that the patient has done, if there has been any. Investigating a woman with recurrent miscarriages, various investigations can be done, and this could include infectious screening. One might need to screen the woman for touches infections that includes toxoplasmosis, rubella, cytomegalovirus, and episymplex virus. Also, endocrinological screening needs to be done for this patient to rule out diabetes mellitus, and also thyroid function test is also important to rule out thyroid disorders. And radiological investigations is important, which will include pelvic ultrasound, hysterosalpingography, and hysteroscopy to actually visualize the uterine cavity if there is any congenital, if there is any abnormality inside the uterus causing this. And also genetic counseling is also important, and the parental genetic counseling is also important, and this will include blood karyotyping of the couple, and also karyotyping of the product of conception after the abortion has occurred could actually be used to rule out genetic abnormalities causing recurrent abortion. Also, immunological, one could try an assay for lupus anticoagulant or anticardiolipin assay could also be assay for, and also factor V Leiden test could also be used. For a woman who has had a recurrent abortion, how do we treat? Education, psychological support, and reassurance, they are extremely important in this kind of a woman who has been having recurrent pregnancy loss. So one needs to educate and support psychologically and reassure such a woman. And it could be a multidisciplinary management in which one will involve a reproductive endocrinologist and with the obstetrician and gynecologist, and a clinical geneticist also could be involved in the management of these patients. And also treatment is directed at the causes as I've outlined earlier. And also, if there is uterine malformation, counseling and surgery could be done. And the genetic causes, parental counseling could also be done. For patients that has autoimmune disorders, preconceptional low dose aspirin, 75 milligram, and also heparin can actually be used before they conceive again. And some have talked about prednisolone also can also be used. And for a patient that has diabetes mellitus, preconceptional glycemic control could also be offered these women before they get pregnant. Then healthy lifestyle modification by stop to smoke, stop taking alcohol, and caffeine intake, and weight loss in patients who are obese are also good in the management, in the treatment of patients with recurrent abortion. And also a patient that has cervical incompetence could be offered cervical sacrilege when they get pregnant again. I will talk about post-abortal care now, which is one of the management for a patient that has suffered an abortion. Management is not complete until one offers such a patient post-abortal care, which is a composite care that is given to a woman and a partner after an abortion. And post-abortal care is germane in the management of abortion. In fact, for a management of abortion is not complete without offering the woman or the couple post-abortion care. Post-abortion care is a global approach towards solving the problem of maternal mortality and morbidity arising from abortion and complications. It's a way of reducing maternal morbidity and mortality associated with abortion, and also in treating abortion complications. It was first articulated by IPAS in 1991 and later published by the Post-Abortion Care Consortium in 1995. And the role of safe abortion services in the improvement of women's health was recognized in 1994 by the International Conference of Population and Development. And what are the components, the essential components of post-abortion care? And there are 5, and I'll be taking them on one by one. The first one is community and service provider partnership for prevention of unwanted pregnancies and unsafe abortion, together with mobilization of resources and ensuring that services reflect and meet community expectation and needs. And this should be the first thing or one will offer as part of the component of post-abortal care that one needs to offer a woman that has suffered an abortion. The second one is counseling to identify and respond to women's emotional and physical needs and other concerns. And counseling is also a germane. The third one is treatment of incomplete and unsafe abortion and its complications, including the use of manual vacuum aspiration. And the fourth one is contraceptives and family planning services to help prevent an unwanted pregnancy and practice birth spacing, meaning that contraception is germane, is important after an abortion. And we need to offer these women family planning so that they could be able to prevent an unwanted pregnancy and also to be able to space their children well. And also the fifth component is linkage to reproductive and other health services that are preferably provided on site or via referrals to other accessible facilities in the provider's network. So I will be dilating on them one by one. Community and service provider partnership. This element of the model recognizes community members that are vital to the treatment, prevention, and advocacy efforts. And the community health education and mobilization have been identified as the key strategies to combat an unsafe abortion. And this includes the use of community leaders and advocacy groups, traditional healers, and formally trained service provider must work in partnership in providing the community and service provider for a woman who has had an abortion, and also to achieve universal local access to sustainable, high-quality post-abortion care and related and health-related services. Education to increase contraceptives use and thereby help women to prevent unwanted pregnancy, birth space, and to reduce unsafe abortion, and participation by the community members in decision about availability, accessibility, and cost of service, and also education about obstetric emergencies and appropriate care-seeking behavior by educating them how to recognize the complications of abortion that could present as emergencies, and what to do after these obstetric emergencies have been identified by them by presenting themselves early into the hospital so that they can access care. The mobilization of community resources, including transportation, to ensure women with obstetric emergencies receive timely care. They should be able to mobilize early for a woman that needs mobilization to the hospital. Also, to access to services for special populations of women, including adolescents, women with HIV or AIDS, and also advocacy for holistic, human rights-based reproductive health policies and services that meet community expectation, priority, and needs, and also for planning for sustainability. Counseling also is one of the components of post-abortal care. It is the vital element of post-abortion care, and ensuring that post-abortion services are not purely curative but also preventive. And it covers more than fertility and contraception. Counseling provides an opportunity to help a woman to explore their feelings about the abortion, access to their coping abilities, and to manage anxiety and to make informed decisions. It is client-centered, and it ensures women, rather than their providers, to make voluntary choices about their treatment, contraceptive methods, and other options. What are the aim of counseling? The aim of counseling is to solicit and affirm women's feelings and to provide emotional support through post-abortion care visits, and to ensure that women receive accurate and appropriate information about their medical conditions, test results, treatment and pain management options, and follow-up care. And also to ensure that women understand how to prevent complications that could result from abortion, and to know when and where to seek care after this complication arises. Also, one of the aims of counseling is to help women clarify their thoughts and decisions about pregnancy, abortion, treatment, resumption of ovulation, and future reproductive health. And also to enable providers to better understand and respond to factors that can affect a woman's healthcare needs, such as experiences with sexually transmitted infection, violence-induced trauma, or the effects of the female genital cutting. Treatment as one of the components of post-abortion care is the first element of the original model and focus of many post-abortion care activities, and it remains the critical part of care both for women who has had an incomplete abortion and also ones that has had unsafely induced abortion. It recognizes that safe, effective treatment involves the use of manual vacuum aspiration, whether applicable standard infection prevention precautions, appropriate pain and management, sensitive physical and verbal patient contact, and follow-up care. And also, family planning and contraceptive services as one of the components of post-abortal care is by making a wide range of birth spacing practices and contraceptive methods for these women, and this will include emergency contraception. Making it available for all women is an effective strategy for preventing unwanted pregnancies and unsafe abortion. And when a facility does not provide these services at the time of treatment, the opportunity may be lost. So each center should try and offer a woman family planning and contraceptive services as part of the post-abortion care in the management of abortion. Also, reproductive and other health services, which is preferred to be provided on site, or referrals to other accessible facility in providers and network. And the following additional services can also be offered for a woman who has suffered abortion. Education about the prevention of sexually transmitted infections, including HIV, as well as screening, diagnosis, and treatment. Also, services addressing gender-based violence, including screening, counseling, and referral. And also infertility diagnosis, counseling, and treatment, nutritional screening and education and treatment of nutritional deficiencies, hygiene education, and screening, counseling, and treatment of reproductive-related malignancies can also be achieved through reproductive and other health services benefits. What are the benefits of post-abortion care? The benefits of post-abortion care. What are the benefits of post-abortion care? It reduces the incidences of maternal morbidity and mortality, and it contributes to a higher contraceptive acceptance rate. When post-abortion family planning, counseling, and services are available at the same time and in the sites as emergency treatment, women are more likely to use these contraceptives. And post-abortion care increases access to family planning, information, and informed method choice. And also, it brings cost savings to facility and clients. For example, using manual vacuum aspiration instead of dilatation and curettage for a post-abortal care can result in cost savings to the facility. Fewer personnel are involved, few laboratory investigations, drug and anesthetics cost, and also it reduces one of other benefits is it reduces repeat abortion. With high quality family planning services, can reduce the number of unplanned pregnancies and can result in a reduction in the number of repeat abortion and attending complications. Finally, how do we prevent an abortion, which I will discuss under the primary prevention, secondary prevention, and tertiary prevention. The primary prevention will entail prevention of unwanted pregnancies that leads to abortion, and the secondary prevention will need increasing women's access to safe and effective methods of abortion, while tertiary prevention entails prompt and effective management of abortion complications. For the primary prevention, promotion of effective contraception for women at risk of unwanted pregnancies, especially the adolescents and the high-porous women. Also, removal of barriers which deny access to contraception to women can also be used as one of the primary prevention, and provision of post-abortion family planning and services. With the secondary prevention, liberalization of abortion laws can be used. Provision of safe abortion services as permitted within the limits of the law. Training of service providers, especially mid-level providers, to decentralize care and increase access for women. Also, provision of manual vacuum aspiration and medical abortion rather than dilatation and curettage or other harmful practices in the treatment of abortion. And integration of safe abortion method into the training crucial of health professionals. And the tertiary prevention, promotion of post-abortion care for the treatment of incomplete abortion, organization of services, including referral services for the management of severe complications of abortion, and regionalization of post-abortion care for the management of severe complications of abortion. In conclusion, complications of abortion and unsafe abortion is one of the major contributors of maternal morbidity and mortality, particularly in Nigeria. Timely diagnosis and provision of post-abortal care by our midwives is the key to eradicating this scourge in our women, especially the adolescent girls, who are mostly at risk. Thank you very much for listening.